few considerations with observational studies. One is temporality. It helps us put things into perspectives. For an exposure to have caused an outcome, it must have occurred prior to the outcome. At least that's how we understand linear time. Prospective cohort studies ensure this by enrolling participants who have yet developed the disease. But we should remember that the timing of measurement does not establish the timing of occurrence. Measuring poverty or BMI at age 50 doesn't mean that they were initially established at age 50. They might have been established a long time ago. Retrospective studies may have an issue with reliability of self-reported measures and participants not being able to remember exactly when exposure happened. Case control begins after the outcomes have been identified, so we have the same issues as with retrospective studies. When exactly did exposure begin? When did it end? When exactly did the outcome develop? What date should we assign to the incidence? In retrospective and case control studies, recall bias is an issue. Those with incidents of heart attack may recall being less healthy 20 years ago than they actually were, since they believe that this may have caused their heart attack. So these things need to be considered when looking at observational studies, the temporality of exposure and outcome. Positivity. A causal effect estimate which includes individuals who could not possibly be exposed is very difficult to interpret. All participants in any study must have a greater than 0 chance of all exposures. So women who are infertile should not be included in a study regarding pregnancy as exposure. Patients who have removed their appendix should not be included in a study of measuring the effect of diet on appendicitis, and so on. And the reason is that obviously your finding is going to be incredibly difficult to interpret. Consistency. Treatment, or whether you want to call it treatment or exposure, varies significantly in an observational study. We are letting individuals to choose on their own. In a study of smoking, some may decide to smoke 20 cigarettes per day, some may smoke 5, some may smoke more on the weekend, some may not smoke at all. In a randomized control trial, we usually try to define very clearly what we mean by a treatment or an exposure. And in this case, it could vary a lot in observational studies because participants can choose on their own, which they to some degree can do in a randomized control trial as well. We need to be consistent in recording the actual dose participants took so that the definition of treatment in our study is well defined. And we don't really have that issue in intention to treat analyses in randomized controlled trials because we only look at allocation and the effect of allocation. In some cases, it might be much more easier and better to use approximate measures for all participants. So how many cigarettes do you smoke per week versus do you smoke every week? Those kind of detailed assessments might not be as useful as more rough estimates in some cases. And then participants may have gone back and forth between your definition of exposure and non-exposure prior to enrollment. Risky drinking, physically active smoker, and so on. If you define risky drinking as some specific level of alcohol consumption here, an individual's alcohol consumption goes up and down. We know that. It varies over time. And so at baseline, you checked were you a risky drinker or not. And on that specific timeline for that specific individual, they were not a risky drinker. But later on they were. So participants may move back and forth between your definition of exposure, non-exposure during the follow-up period. And this is generally a quite a difficult thing to deal with and probably quite an underreported issue, I would say.